Hi guys, Dr. Douglas Gillard here. Every now and then I have a really interesting case, and I think this one fits the bill. It's the case about a patient with foot drop. Now that's not so really exciting. It's a common thing, but what is exciting is that we actually have some video of the muscle testing, and we can see with our own eyes the severe weakness. For my students, that's going to be great because they've never seen a case of real foot drop with real dorsiflexion weakness on examination, so it's pretty cool. And there's a surprise. When I go over the MRIs, I find something that in and of itself can be a surgical indication. But in this case, it is an asymptomatic finding. So I won't say any more about it. I'll let you watch the movie. So I hope you enjoy. I'll talk to you after the end of the examination just to wrap things up. So the patient is a 60-year-old male, lives in the Far East, doesn't speak English. So I had to use his brother. Actually, his brother's the one who contacted me following this second injury. The patient's severely incapacitated after that, and we'll talk about that. But very tough time getting the history from both of them because there was such a communication problem. But I think I got it pieced together pretty good. So he originally hurt himself in 2015. He had a slip and fall injury, and it looks like he hurt his right lower extremity, ended up with some chronic pain and disability, but not a really big deal. He never sought any medical attention or got any kind of medical treatment, maybe some massage every now and then, but life was okay. And no low back pain. He's never had low back pain, so keep that in mind. Now, fast forward to February 2018. He was pulling weeds and cutting grass, hand cutting grass, which I learned is not weed whacker, not a lawnmower. It's the old sickle where you bend over and twist, which is the worst possible thing that you could ever do for a disc, right? Bending and twisting combination. So that doesn't surprise me. He blew out his disc doing this, amongst other things. So he's in severe pain and weakness in the right lower extremity, and he couldn't walk, which really scared him, so he called his brother, unable to walk. The brother contacted me. We set up a consultation session. I got the MRI, got the information, and here we are. So again, no complaints of low back pain. Keep that in mind when you look at the MRI images. Okay, no complaints of bowel or bladder. Perineum was good, no numbness, no hesitancy going to the bathroom, so everything was good. I think even before this case occurred, he was limited in his ability to walk. He couldn't walk for miles and miles, but he was good for a few kilometers at least. All right, now examination findings. I mean, I can't, usually with my coaching sessions, I am speaking with a client. I can turn on my webcam if I need to and go through some crude neurological testing with a patient, have them walk on their toes, do single leg calf raises, walk on their heels, have them get up out of a chair. You test all the basic stuff. Get a stick or a cane or a crutch or a golf club. Test the extensor hallucis longus. And for all you students, what are the nerves associated with those? Let's start with, how about getting out of the chair? What's a good group there? That's your, what is it, the answer there? Quadriceps, so that's probably L3, maybe a little L4, maybe a little L2 in there. How about the extensor hallucis longus? This is a classic one, L4, right? And these nerve root injuries are at the disc level or in the vicinity of the spine. How about the extensor hallucis longus? L5. What about the gastrocnemius? S1, so only one left. Now, those are about 70% accurate. There's definitely overlap. I've seen people with full-blown foot drop who've had L5 root problems only or L3 root problems. It's usually L4, though. Okay, get the idea there. The cadavers, as we know from our gross anatomy lab, are very anomalous. All right, so that's why those don't work perfectly. So I wasn't able to do this, but the patient's relatives were able to make a video and had them do, they forgot to do all the tests, but they did some of them, and they did the most important one. So I'll leave you right now. Let's take a look at that video. I'll come back after that.
好了，预备开始动。 左脚是正常，右脚现在可以抬高一点点，本来是完全搭地不能抬高，现在可以大拇指的地方这样子，有没有看清楚？有没有？可以抬高一点点了。OK， 这个是现在的现象。
Okay, well, that was pretty interesting, right? A lot of you have never seen anything like that before. That was a real live foot drop against gravity. Nothing. I mean, he couldn't. Maybe a tiny, tiny bit of movement against gravity. So here's that old MRC scale. You guys should be familiar with this. This is used. I work for several spine surgeons over the years. Everybody uses this. It's 0 is no contraction, 5 is normal. If it's 4, any of the 4s are considered a moderate weakness. Anything under 4 minus is bad news. That's considered severe weakness, and that's just a general rating scale used by everybody. So, how would you rate our patient based on that video? Well, he definitely had some contraction, right? He got a little tiny bit of movement against gravity. So active movement with gravity eliminated. Now he could just maybe tiny, so I would probably call that a 3 minus. But he's got severe weakness. So what are the emergency indications for surgery? Number 1, cauda-equina syndrome, right? Problems with the bowel or bladder. Number 2, severe intractable pain. You're almost in the hospital, probably in the hospital, in the emergency room. So the third one is a progressive, now watch the word, progressive loss of motor reflex. So he is really close to the camp of emergency surgical candidate because he's got severe motor weakness. But now I just talked to his brother. I emailed his brother this morning, and he's actually doing a little better. So we'll talk about that at the end. Okay, so at this point, let's switch over. I have another video of me going over his MRI images, and you're going to perhaps see some surprising findings. So I'll be back to finish this off with you. All right, let's check out his MRI images now. I have his sagittal views and his axial views up here. I'm using ONUS 2.5. Now I'm going to assume you know how to read MRI. I'm not going to go through that here. I have plenty of videos. I'll put some links down below. I have several videos on how to read your lumbar MRI. So go check out those videos or you're going to be lost here. So we have the sagittal view over here on the left side, and on the right side we have the axial view. Remember, whatever the orange cut line goes through on one image, we see the opposite, or we see exactly what that's going through. For example, it's going through the L5, 4, 3, 2, 1. So this is the L1 disc, right? So we have a cut right through the L1 disc, and that's exactly what we're showing up over here. The only thing you have to remember is that we're really looking from the bottom up, so these images are reversed. So this is the left side, this is the right side over here. Okay, everybody good? And we started off here. Let's kind of get warmed up. This is a good looking disc here. Of course, it's a little degenerated. The patient's 60 years old, but you can see a little white region where the nucleus pulposus is. Now, foot drop and sciatica, radicular pain, radiculopathy, we're very interested in the 4 nerve roots that are close to the back of the disc. So here is the right exiting L1 nerve root. Here is the right traversing, which one? L2 nerve root. These are going to come out about at this level here. They're going to butt off the thecal sac, and then they're going to come out the IVFs. These are the intervertebral foramen right here. Right, and then here you can see the sensory and motor component of the left L2 traversing nerve root, and there's the exiting L1 nerve root right there. Okay, so those are the 4 players. Remember, the thecal sac is in the middle. There we can change some color a little bit so we can see it better. Okay, see the thecal sac right here? You can see all the nerve roots. Everybody's life is great. But keep this in mind. Life is great. You can see the cerebrospinal fluid. There's little dots. Those are all the traversing nerve roots, or collectively they're called the cauda equina. Filum terminale would be right in the very center there. Okay, so life is great. Facet joints are back here. Remember, he has no low back pain, right? Zero low back pain. It's all right leg symptomatology and foot drop. Okay, put that back the way I like it. All right, now the first thing I want to do though, let me get an idea of, the first thing I notice is that his spinal canal looks a little squeezed to me. Let's go up here to the back of L1. This should be 20 millimeters, and there's no way that's 20 millimeters. Okay, that's 13.89 millimeters. So and that's being generous. So he's got canal stenosis. This is something he was born with. What does that mean? That means that a little 4 millimeter disc herniation in him is like, assuming you have a normal size canal, lots of room in here, that's like an 8 millimeter herniation in you. There's less wiggle room because this pipe, which allows the cauda equina to hang in, is narrowed. And you can see down here, now it tapers a little bit sometime down here, but at the that's 11.63. So that's nowhere near 20 millimeters. So he was born with congenital scoliosis, or not congenital scoliosis, but congenital central vertebral canal stenosis. So that's one of his diagnoses. Okay. So now for completeness, when we're looking at these, you always check. Let's check the IVFs. We're checking them from overhead. They look great. I could drive a truck right through here. But let's check them from the sagittal view as well. So I'm gonna left click over here on the disc, and that's going to be able to switch the cut line. Oops, sorry. I'm going to left click over here on the sagittal because that's what I want to show. And now let's take a look through that right intervertebral foramen. And it's a little narrowed, but you can still see the nerve root. There's the IVF right here. Everything's great. There's the pedicle. This is L1 still, right? 5, 4, 3, 2, 1. Yep, L1. There's T12. L2. We can see L2 is getting squeezed. Ooh, wow. Look at the problems down here. Holy smokes. Yep, we're cheated. We jumped ahead. So we see some major stenosis here. Lateral stenosis down here at 3, 4, and 4, 5. 5S1 looks okay again. But we're cheating. Forget I said that, because I like to go level by level. And just for completeness, let's jump over to the other side. These probably will be more open. Okay, they're a little narrowed, right? But they're not as bad as the other side. But we'll do them level by level. All right, so that's it there. Let's move down. Let's take it down. Now here's one thing that drives me crazy. Now so watch the angle of the cut line. So the technologist did a great job. Perfect cut through the disc. He or she gets a gold star. Not a perfect cut through the disc, but look what happened. We got a big hop here. Look at that. And there's a little funkiness going on there in the thecal sac, which I would like to take a look at, but I can't. See that? A little weirdness there, but I really can't, because the technologist did not give me a cut through every single nook and cranny. So that's annoying. Usually on the T1 they'll do what's called a stack series, and they won't bother with angling. They'll just run but they'll cut every single inch of this, or every single millimeter. So that's kind of annoying for me. But anyway, let's get back in the mid-sagittal view, which that is. And jumping ahead already. This is mid-sagittal view. Look at the stenosis here. But let's stay focused. Okay, let's go down to the next level now. So here we are. That's 3, that's 4. This is the L3 disc. And now, whoa, what happened over here? Let's go back up. Remember what it looked like. Look at how beautiful the cerebrospinal fluid is here, right? Everybody's happy. no problem. You can see the nerves, and look what happened. Bam! That is severe central stenosis. And we got, if I play around with the contrast, it looks worse on the left, doesn't it? Because you can see some funkiness right in here. So let's put a cut through there and check out that traversing. So if this is 5, 4, 3, 2, if this is the traversing L3 nerve root, remember, can the L3 nerve root cause foot drop? It could contribute to it, but not on this side. This is the left side, so this is asymptomatic apparently, because the left side was okay. Okay, I'm going to blow this up now too. Let's remember that this is L3, that little shiny corner there, and that funkiness, that's in L2. Let's put a cut through there and see if we can ascertain what's going on over there. Okay. Oh my goodness. Now that is a surprise, isn't it? This is the surprise I was telling you about. What do you guys see? Now you students who have had my class before, which I no longer teach, don't get me started on that one. You guys probably know. And my followers, what is that? You see it? Remember, we saw some funkiness here, but we had to go to the sagittal view to confirm. Look at that. What is that? That's a huge fragment of disc herniation. That is a big fragment of herniated disc. I mean, I have plenty of clients who've had surgery for things like that. It's a 12 millimeter fragment, 13 millimeter fragment. So, but what is the amazing thing here? This just goes to prove the point. You can't look at an MRI and say, this guy needs surgery. This has to be removed, because it's on the left side. Look where it is. See how that works? It's probably got not so much the traversing, it's probably got the exiting root where it's butted off. So if this is 2, is that where we are? Let me see where we are. Yep, we're at 2. So if this is 2, that's the L2 exiting root. So remember I said the L2 exiting root buds off right about in here. So why this is not symptomatic? It just must be just placed just perfectly, because he has no symptoms on the left side at all. So that's a great lesson for you guys and you primary healthcare docs out there, or anybody, that you can't always judge a book by its cover. All right, so that was crazy. Okay, let's go down a kind of see if we now see this would be handy if we could have a stack series. I could see where it starts and stops, but I guess it's not. I mean, you can still see it here. It's already starting to indent the thecal sac a little here. Here is this is 2, so that's the exiting L2 nerve root's fine over here on the right, but over here, I mean, where is it? It's kind of pushed back over here. So it's definitely, that's a fragment. The one good thing is, look at the color of it. It's a little bit lighter than the parent disc. Now there's no research on this, but in my experience, a lot of times when it gets light like this, that's an indication. If we did another MRI, this was done last month in March. If we did an MRI in 6 months, maybe this wouldn't be there anymore. It's a good indication that it's naturally reabsorbing. It doesn't always work out that way, but there is certainly a chance of that. Okay, so surprise. All right. But as far as the symptomatic side is concerned, oh, what else? Boy, this is a busy level, isn't it? So let's go down more. So now what do we got? Look at this. Here's a cut right through the bone. No, is that off? I think the cut might be off a bit. But we got this big thing right here. Look at this. Okay, here's the exiting left, exiting L2 root. Now the exiting right L2 root is pushed off over this way. So it's actually contacted by this. This looks like a big bony spur to me. Let's go check it though. Let's go put a cut through that and see if we can make heads and tails of that. Okay, so the disc is bulging a little bit here. Here's the back. No big deal. Still, well, now it's sticking out a little bit, so we got a little herniation going on here. Let's keep going. There's a little bone spur coming right over the top of it. And there it is. See, this is all bone spur over herniation, a broad base herniation. So this is a disc osteophyte complex right here. But again, now this is the L2 nerve root. So, although he has weakness in his tire, I wish I was able to examine him more thoroughly because there's definitely some compression going on there as well. But normally the L2 root's not going to contribute to his main problem, which is the foot drop. All right, so we're good. I think, boy, that was a busy level, wasn't it? That was L2. And we didn't check let's check the L3 nerve root, traversing root, which would be right in here as well. So that's a little tight in there too. So we could be getting some compression of the L3, traversing L3 nerve root on the right here as well. See how much more open it is here? Now we're in the lateral recess at the start of the IVF. It should be this big. See, it's really here. And then down below, it's terrible. I mean, all three of these levels. So it could be a 3-level, kind of a lateral at the start of the lateral recess, or lateral stenosis. So it could be getting some compression there. Maybe that's why the foot drop is so bad. Go down another cut. There even looks like there's some funkiness right in here. It could be another fragment of disc. Let me see if I can see what that is. Kind of jumping over, but I think that's just part of the disc herniation. And it's, I mean, we can measure that. Let's see. So he's got spur. I'd probably measure it. Here's this corner of the bone. I'd probably measure it from here. Don't include the spur. It's about a 7 millimeter broad base protrusion there, right in the IVF. So that's not a good thing. So is that contributing? Well, what would you do, students? My old students would know what to do there. You do a selective nerve root block right here. Let's see if that takes away any of his symptoms. Right? I'm not going to take too much time. Okay, so pretty interesting. And okay, I think we've said enough. And you can see that there's no cerebrospinal. This is severe central stenosis. I'll say severe lateral. Well, I got to save it's worse down below. So now I'm still going to say severe lateral stenosis as well. So this is, I mean, that's got to be opened up. Okay. So let's go down. Still doesn't look much better here. There's a kind of a central fragment right there. You can still see the fragment here, but again, it's on the wrong side. It's a fragment of disc herniation. That is a big, that thing we saw went from here all the way up down to here. So that disc is pretty much, has spit out a lot of material. Now we're starting to see a little bit of cerebrospinal fluid come back, which is great as we go down. The facet joints look good. I don't see any slip. Ligamentum flavum is right here. Below this black stuff, it's a little bit, it's hypertrophied, but it's not insanely hypertrophied. All right, let's go down the next level. Now we're at the L3 disc. It's same story. We got how big should the thecal sac be? Anything under 10 millimeters is central stenosis, and this is way under. This is 5.75. Now, this is another complaint I didn't say. He can't walk for super long distances, and this is why right here. This is severe central stenosis. So he's got undoubtedly NIC. What's NIC, students? Nick and Vic. NIC is neurogenic intermittent claudication. I have a tape on stenosis. You can look that up. But this needs to be decompressed if he wants to try to get his ability to walk back. Pull this up a little for you too. All right, so let's kind of see what's going on here. Nerves are getting a little sticky. See, he's getting a little arachnoiditis. The nerves are sticking together, which doesn't mean, very rarely does arachnoiditis go off and cause all kinds of crazy symptoms. It happens, but it's pretty rare. But it's very common to see in stenosis. This is arachnoiditis, but it's very commonly asymptomatic and really almost an incidental finding because these nerve roots are all smashed together and they're just starting to kind of pull apart from each other. Okay, let's go. So now we're getting down where we were at 3. So the L4 nerve root, I mean, where is it? You can't even see. I can't even see either one of them on each side. It would be right in here. So we're going to have to go to over here to take a look. Let's put a cut right in there and see, because now this is the star of the show, right? This is the L4 nerve root. I mean, it's just, let's see if we can even see the thing. It's just completely smashed in here. Can't even see it. This is all disc herniation versus bulge. And see how it's open down here? That's how it should be. See how we can see the nerve root here? There's the S1 traversing. L5 traversing is right there. The star of the show, you can't even see it. It's completely smashed. This is all ligament and flavum thickening, and that's a disc protrusion there. A little bit of osteophyte complex, some modic change in here as well. So this is the problem right here. There's zero room. Up above there's a tiny bit of wiggle room, but not much. Here it's severe lateral recess encroachment, and the traversing L4 nerve root, the traversing right L4 nerve root is just getting hammered. It's getting hammered, smashed, inflamed so bad here it doesn't work. And all the dorsiflexors, all the gang aren't. A lot of the axons have died and the muscle is flaccid and not working. So that needs to be decompressed in order to have some hope of, I mean, he might gain some strength as the body kind of accommodates to this, but he's not going to gain that. I seriously doubt if that foot drop will ever come back. Even if they decompressed it now, because remember he had an injury earlier on, so he had a little bit of weakness. It may be too late for that to come back. All right. I think that's about all we need to see right there. We could go look down at L4, of course, because there's the L4 root right there, right? So we're just above the disc. There's the L4 disc. There's the L4 body. Okay, well, it looks like we got a bulging disc, but there's the L4. That one looks okay there. We want to make sure there's not a double crush. Let's go down. Disc is thin. Whole disc is bulging. Stenosis is not as bad, is it? It's still, let's see what that canal is, or that thecal sac. It's still, it's 9.55, so it's under 10, so it's just moderate stenosis here, moderate central stenosis. Let's pull this up on the other side. All right, so we got some lateral recess stenosis as well, but look, it's not, I mean, you can see the root in here. That would be the L5 root now. L5 root, there's plenty of room for the L5 root coming through. But yeah, up here is not a good thing. Okay, let me just jump over and check that IVF here. So there's the L4 root, looks okay over here. There's a little bulging there, but that's no big deal. Compared to that up above, it's fine. Now it's really smashed there though, isn't it? That's right in the framing itself. There's no room for it. So that 4 we could be getting a double crush, right? We should, let's go up to 1. Remember, we should at least be able to see a little bit. That's still stenosis, but you can see the nerve root in the IVF. I mean, where is it here? I challenge you to even find it. It's just completely crushed. So he's getting double crush. It wasn't down there, but it wasn't in the lateral recess, but it's actually in the foramen where he's getting. See, it's there. There you can see it. There's the L4. If I go one more cut out, or one more cut back, right at the start of the intervertebral foramen, it's smashed really bad. So, yep, the 4 is gotten. Let's see, that's L4, 5, and L3, 4. It needs a decompression to open that up. Remember what a decompression is? What is a decompression? No, that's a clean-out operation. It's usually a laminotomy, foraminotomy. They remove ligamentum flavum. And if there's fragments of herniation, they do a discectomy. So it's kind of a clean-out procedure called decompression. All right, I think that's about it. Probably went longer than I wanted. Jump down here at L5. I'd like to see an x-ray. I'm not convinced that he might have a transitional segment. That's an awful small thecal sac. It's possible that could be S1, but I don't think so. I'd have to see an x-ray so I could, or CT that went all the way down. But this is, if this is L5, these are the S1 roots here already out, and those are the L5 traversing root or exiting roots. Sorry, these are the S1 traversing roots. They're already out of the little baby thecal sac, tiny one. And there's, you can see, you can follow them all the way out the anterior sacral foramen, or heading that way. Okay, I think that will do it. So pretty interesting, right? We saw that fragment, that sequestered disc, but apparently completely asymptomatic because it was on the side away from any of the symptoms. All right, I will hand it back off to myself. See you in the next video. Okay, well, I hope you learned something from the MRI review. This has been a really interesting case. Let's review what's happened here. So we have a patient with severe motor deficit at the dorsiflexors of the right foot. This is secondary to a double crush type injury, severe lateral recess stenosis at 3-4 and foraminal stenosis at 4-5. Both of which are crushing the nerve root in two places. So that's the motor axons within that nerve root have been, many of them have died and they don't work as dorsiflexors, so he can't lift his foot up at all. So that is one of the emergency indications for surgery, for decompressive surgery. Now you could, you could justify doing a discectomy today on this patient because the foot drop is so bad. You could give it a little time to see if it comes back to life, but I wouldn't monkey around with it. Most of the surgeons I know like to do this within 4 months, which is approaching for him very soon. He's had 2 surgical opinions already. The first one wants to do a 3-level interbody fusion with decompression. I'm sure they didn't say that, but I'm sure he meant decompression. And the second one wants to do an artificial disc, same thing, 3-level ADR with decompression, I assume, as well. The ADRs in this country, let me just talk just a second. ADRs have, in my opinion, have really fallen out of favor. They were designed to prevent adjacent level disease, and they haven't done that. The research really hasn't shown they prevent an adjacent level disease any more than a TLIF or PLIF or ALIF does. So I don't particularly like them. I know several surgeons who dread the things. Revision's very difficult sometimes to get those things out of there, so I'm not a fan of those. But the third surgeon, this is what I recommended, just a simple decompression without fusion. Now, the wild card is assuming he's stable. He hasn't had a flexion extension study. So we got to make sure those bones aren't slip sliding around. But if he's stable, I think that a 2 or 3 level decompression to free up that L4 nerve root, probably a 2 level should do the trick. And keep our fingers crossed. Maybe it'll make him a little unstable, but the research says even if people get a little bit unstable, sometimes they still have pretty good outcomes. So that's what I would have him consider. He's going to another surgeon, a third surgeon, to talk about that procedure. So I would be in that camp if that's what he thinks needs to be done. So, all right. So I just want to take a few minutes here to talk about a service that I do render to the general public. So I offer a consultation service. I call it coaching service. And if you are confused about what to do, you have low back pain, and it's been going on for months and months, and it's not getting better, and you've been told different things by different doctors, this is what I like to do. I like to come in, try to help you figure out something and make evidence-based treatment suggestions about what to do about it. I use a program called GoToMeeting where we will meet. You will upload your MRI images or send them to me in the mail, or CT or discography or whatever you have, the more the better. We'll go over them with a fine-tooth comb with you watching. You can use a pointer on my desktop and point out things that you have questions about. And it's just like you're sitting right here beside me. I have you do some neurological testing, like the ones in this movie. So I can get a pretty good story by doing this, I think. And if you're a little hesitant, make sure you check out my testimonials, because I've been doing this, let's see, since 2003. That is well over 10, that's like 15 years. So I've got a lot of experience doing this. I'm a neutral opinion. I don't work for anybody. I'll tell you the truth. I'm not going to sugarcoat anything, but check out my testimonials. I've got a lot of medical professionals on there, MDs. I have radiologists, I have a rocket scientist, I have a priest, I have a chiropractor, physical therapist, acupuncturist, you name it, lots of engineers, website designers, moms, laborers. So go check that out and see what they're saying about the service. All right, again, I hope you enjoyed this presentation. I have two other interesting ones coming down the pike here, so we'll see you in the next video.